Okay, let's just jump right in. We're doing a rapid, high-yield deep dive into local anesthesia.
Right.
This is pure principles, pure pharmacology, everything you absolutely need to know for your board exams.
Exactly. And the foundation, the place we have to start, is the mechanism.
Okay.
Local anesthetics produce a reversible loss of sensation. They do this by blocking the voltage-gated sodium channels.
So they stop the nerve impulse before it even starts.
Precisely. No sodium influx, no depolarization, no pain signal.
So that blockade is the key action. But before we get into the kinetics, let's talk structure. How are they classified? And what's the one feature that dictates both how they're metabolized and, more importantly, that risk of anaphylaxis?
It all comes down to the intermediate linkage in the molecule. That's it.
Okay.
Based on that, we split LAs into two groups, the amides and the esters.
Give us the quick memory hook for the exam, the one everyone uses.
For sure. If you look at the generic name, amides almost always have an I in the first part of the name.
Like lignocaine, bupivacaine.
Exactly. Lignocaine, bupivacaine, prilocaine, these are the modern workhorses.
And they're metabolized where?
In the liver. And that's key because it means they very, very rarely cause true anaphylaxis.
Okay, so that brings us to the esters. Less common now, but a much higher risk profile.
Right. And esters, you'll notice, don't have that second I. So procaine, tetracaine, chloroprocaine.
And their metabolism is the whole story.
It is. Esters are broken down right there in the plasma by pseudocholinesterase. It's very rapid.
And this is where the allergy risk comes in. It's a classic exam question. Why does that specific metabolic pathway make them so much riskier?
It's the byproduct. It's the metabolite. When pseudocholinesterase breaks down that ester link, it produces paraminobenzoic acid.
PABA.
PBA, and PABA is highly, highly allergenic. It's the single culprit for almost all true LA allergic reactions.
So if a patient's chart says LA allergy, you have to be thinking PABA.
You immediately think PABA and you think ester.
That is a huge safety point. Okay, let's pivot to pharmacokinetics. We know the LA molecule has to be in its ionized, its charged state to actually bind to the sodium channel.
That's right.
So logically, why doesn't making the solution more acidic, which would create more charged ions, actually make the block work better?
This is probably the most critical concept to grasp, the ionization paradox. You're spot on. The drug has to be charged to do its job inside the nerve. But charged ions can't get there in the first place. They're polar, so they can't cross the fatty nerve sheath, the epineurium and perineurium.
So the drug has a two-stage mission. It has to be neutral to sneak across the membrane.
Right, be stealthy.
And then once it's inside, it has to become charged to actually block the channel.
Exactly right. So the drug needs to be in its non-ionized, its uncharged state to diffuse across the membrane.
Which means the speed of onset is all about how much uncharged drug is available.
It's directly proportional to it.
And that ratio between charged and uncharged is all governed by pK.
It is. And pK, just to be clear, is the pH at which the ionized and non-ionized forms are in perfect balance. 50-50.
So for a fast onset, you want an LA with a pKa close to body pH.
Close to 7.4.
Give us the classic example.
Lidocaine. Its pKa is 7.6. That's very close to 7.4.
So a huge chunk of it is already in that non-ionized, ready-to-diffuse form.
A huge chunk. Now, compare that to bupivacaine. Its pKa is 8.1.
Much further away.
Much further. So at body pH, fewer of its molecules are uncharged and ready to cross. That's why its onset is so much slower.
Okay, let's apply this clinically. Why do local anesthetics so often fail when we're trying to block an infected or inflamed area?
It's the PK principle in real time. Infected tissue is hypoxic, and that leads to an acidic environment. The pH drops.
And that acidic environment pushes the equilibrium.
It shoves it way over towards the ionized charged form, the form that can't cross the membrane, so the block just fails.
So if acidity is the enemy here, what's the simple clinical trick we can use to boost the effect?
Alkalinization. Just add a little sodium bicarbonate to your LA solution.
What does that do?
It temporarily raises the local tissue pH, pushing the equilibrium back towards the non-ionized membrane crossing form. It speeds onset and improves the block.
Got it. Now, quickly on duration. We know bupivacaine lasts forever. Why?
Two big factors: lipid solubility and vasodilatation.
Okay.
Bupivacaine is highly lipid soluble. It loves fat. So it binds really tightly to those fatty nerve axons and just sits there. Slower start, but it lasts all day.
And the vasodilatation.
All local anesthetics cause it.
Except one.
Except cocaine, right. And that increased blood flow basically washes the drug away faster, shortening the block.
Which is the perfect lead into our next topic,
Okay.
adjuncts, specifically epinephrine.
Right, epinephrine, we add it to counteract that washout. What's its dual function?
It's a vasoconstrictor. That's its whole job. It clamps down on local blood vessels.
Which reduces absorption.
Exactly. And by slowing that absorption, you get two massive benefits. One, you prolong the block. And two, and this is the big safety one, you lower the peak systemic drug level.
Reducing toxicity risk.
Massively. What's a safe max dose guideline we should all have in our heads for epinephrine?
It is variable, but a good safe number to remember is 4 micrograms per kilogram.
And in terms of concentration?
We usually see 1 to 200,000, but there's good evidence that even 1 to 1,000,000 is probably just as effective. But you have to remember to cut that max dose way down in patients with, say, severe heart disease or thyrotoxicosis.
Okay, let's just tackle the elephant in the room. Epinephrine in digital blocks. Fingers, toes, nose.
And hose, yeah. The old dogma.
Can we be crystal clear on this for anyone listening?
Absolutely. The current robust evidence shows there is zero proof that using epinephrine in concentrations up to 1 to 100,000 in a digital block causes infarction.
So the fear is outdated.
It's outdated dogma that leads to worse pain control. It's safe and beneficial.
Good. Okay, let's get to the part everyone dreads on exam day. The math. We have to convert percentage concentration to milligrams per milliliter. Simply. How do we do it?
This has to be second nature. You multiply the percentage by 10, that's it.
So give us the ones we see every day.
Lignocaine 1%, that's 10 milligrams per ml. Bupivacaine 0.5% is 5 milligrams per ml.
What about bupivacaine 0.25%? We see that a lot.
Just move the decimal. 2.5 milligram L, always multiply by 10. You can't calculate your max safe dose without this.
And for epinephrine, say 1 in 1,000.
First, convert the ratio to a percentage. 1 in 1,000 is 0.1%. Then apply the rule.
Multiply by 10.
So that's 1 milligml. But a word of caution, these maximum doses are just guidelines. They don't account for patient size or where you're injecting. You still need clinical judgment.
Let's shift to the specific agents, the big four. And let's start with the one that demands the most respect for its toxicity.
That has to be bupivacaine. It's fantastic for its long duration. I mean, it can last up to 24 hours.
But the max safe dose is low.
Very low, 2 milligrams per kilogram. That's with or without epinephrine.
And what's the absolute non-negotiable warning?
It is profoundly cardiotoxic. It binds cardiac sodium channels so tightly that if toxicity occurs, resuscitation is incredibly difficult.
So it should
It must never be used for a Beers block, ever. The risk of tourniquet failure and a massive systemic dose is just unacceptable.
So why do we see levobupivacaine used sometimes?
Bupivacaine is a racemic mixture of two isomers. R and S, levobupivacaine, is just the S isomer.
And that makes it safer.
It's demonstrably less cardiotoxic. The max safe dose is a bit higher, maybe 3 milligram a kilograms, but the data is a little more limited there.
Okay. Next up, the workhorse, lidocaine.
Or lignocaine. Rapid onset, pretty short duration. It's the standard for quick infiltration.
Dosing.
3 milligram plain. But you can push that all the way up to 7 milligrams with epinephrine.
And our last one, prilocaine. Less toxic than lidocaine, but it has a very strange complication.
It does. It's less toxic because it's metabolized so quickly. But if you give a really high dose, over 600 milligrams total,
it can cause what?
Methemoglobinemia.
That's when the patient's skin starts turning blue, but the pulse oximeter reading is weirdly normal.
Or deceptively low, yeah. The hemoglobin gets oxidized, so it can't carry oxygen anymore. You get cyanosis, but the pulse ox is unreliable because it's not designed to read that form of hemoglobin.
And the treatment for that?
Most cases are benign and resolve on their own pretty fast. But for a severe case, you give methylene blue, 1 milligram IV over 5 minutes.
Because it clears so fast.
It's the drug of choice for a Beers block.
Okay, let's zoom out to systemic toxicity in general. Asked, what are the signs from early to late stage?
Right, and remember, this can be delayed for hours. It starts with the CNS at lower doses.
What does that look like?
The patient might feel dizzy, lightheaded. They might complain of a metallic taste or numbness around their mouth, circumoral paresthesia.
Those are the early warnings.
Exactly. If you miss those, it progresses. You'll see shivering, muscle twitching. Then you get generalized tonic-clonic seizures, and finally, coma.
The cardiovascular signs come at higher doses, and they're much more dangerous.
Much more. It starts with cardiac depression. So sinus bradycardia, which can progress to sinus arrest. And at really high levels, you get vasodilation. The whole system collapses.
And with bupivacaine specifically.
Because of that high binding affinity we mentioned, it's notorious for causing refractory ventricular fibrillation.
So let's say the worst happens. You have a circulatory arrest from last. What are the immediate steps based on the guidelines?
This is a protocol you have to know cold. First, and most obviously, stop injecting the local anesthetic.
Step 1.
Step 2, call for help. Announce last so everyone knows what's happening. Third, manage the ABCs. Airway, breathing, 100% oxygen, and control any seizures.
If you're starting CPR, what's the antidote?
Start high-quality CPR. You can treat arrhythmias conventionally, but with one massive exception.
Do you know that used?
Do not use lidocaine. You will just make the sodium channel blockade worse. The definitive antidote is lipid emulsion therapy.
Intralipid, 20%. What's the protocol?
You give 1,000 milliliters of 20% lipid emulsion. And here is a huge exam trap.
I think I know what you're going to say. Propofol.
Propofol. It comes in a lipid emulsion, but it is not a substitute. Propofol itself is a major cardiovascular depressant. You'll just pour gasoline on the fire.
And what's the last thing to remember during that resuscitation?
You have to be persistent. Recovery from an LA-induced cardiac arrest can take over an hour of sustained effort. Don't give up early.
Okay, that was a lot, but incredibly high yield. We've covered the amide versus ester difference with the PBA risk, the PK paradox for onset speed, the vital role of epinephrine,
the specific toxicities of bupivacaine and prilocaine,
and crucially, how to recognize and manage last with intralipid.
Right. And knowing these principles, being flawless on your dose calculations, knowing why you never use bupivacaine in a Beers block, having that toxicity protocol memorized, that is what defines safe practice.
It's the difference between a routine block and a catastrophe. Now, a final thought for you to take away from this. We talked about how local acidosis in an infected wound makes LAs fail. So thinking about that and the pKa of an agent like lidocaine at 7.6. If you're planning a delayed reconstruction on a wound that's already looking a bit inflamed, maybe colonized, do you just increase your dose to try and brute force the block? Or is it actually mandatory to pre-treat that tissue with sodium bicarbonate, even without a confirmed infection, just to guarantee you get adequate anesthesia on the first try? Something to think about.